Coumarins are well absorbed after oral administration. Oral administration means that food can be an interfering factor in drug absorption. Other interfering factors may be the gut flora and medications. Now, all these factors may increase the level of vitamin K. They are the main source of three types of vitamin K derivatives: K1, K2, and K3. Well, vitamin K1 is known as phytomenadione chemically, and its main source is the green vegetables like cauliflower. K2 is also known as menaquinone, and it is mainly synthesized by the normal flora of intestine. Vitamin K3 is synthetic form, and it is chemically known as menadione. It is usually administered as a supplement in case of vitamin K deficiency. So, as these interfering factors may exist, you need to adjust the dose to balance between the opposing risk of bleeding and the thrombosis. After the dosage has been titrated successfully, loss of control may occur if certain interfering factors are ignored. Like if the patient changes diet habits and consume more vegetables, vitamin K may predominate over the vitamin K antagonists. If vitamin K producing gut flora is damaged during the antibiotic therapy, the antagonist may prevail. Drugs that increases the hepatic biotransformation via the enzyme induction may accelerate the elimination of hydroxycoumarin and thus lower its blood levels. Likewise, the inhibitors of hepatic biotransformation augment the action of hydroxycoumarins. These interactions can be broadly divided into two categories: pharmacokinetics and pharmacodynamic effects. Pharmacokinetic mechanism of drug interactions which mainly involve hepatic enzyme induction, enzyme inhibition, and reduced plasma protein binding. Now, pharmacodynamic mechanism of interactions are synergism, that is the impaired hemostasis, reduced clotting factor synthesis, or that occur in case of hepatic disease. The next is the competitive antagonism, like that occur in case of vitamin K excess. An altered physiological control loop for vitamin K, for example in the hereditary resistance to oral anticoagulants. The most serious interaction with warfarin are those that increase the anticoagulant effect and risk of the bleeding. The most dangerous of these interactions are the pharmacokinetic interactions with the mostly obsolete pyrazolones, phenylbutazone, and sulfenpyrazone. These drugs not only augment the hypoprothrombemia but also inhibit the platelet function and may induce peptic ulcer disease. For this reason, neither phenylbutazone nor sulfenpyrazone is in common use. Aspirin, hepatic disease, and hyperthyroidism augment the warfarin's effect. Aspirin by itself effect on the platelet function, and the later two by increasing the turnover rate of clotting factors. The third generation cephalosporins eliminate the bacteria in the intestinal tract that produce vitamin K, and just like the warfarin, they also inhibit the vitamin K epoxide reductase. Cholestyramine binds to warfarin in the intestine, and this reduces its absorption and bioavailability. So this was all about the vitamin K antagonist. What they are, how they perform their role inside the body, in which diseases they are used, and what are the adverse effects and drug interactions of these drugs. Hope you are well familiar with vitamin K antagonists now. For more lecture, keep watching sqadia.com.